Hello everyone, this is Dr. Harsha, consultant endocrinologist from Bhimavaram. Today we'll be talking about a case study of diabetic patient and the importance of treating them properly. We'll be seeing a case of 58-year-old male patient who had a history of diabetes since 4 years, who is obese, hypertensive, has hyperlipidemia, has obstructive sleep apnea. On his physical examination, the patient is obese with an BMI of 32 kg per meter square. His hypertension is 130 by 82 mm of Hg, and heart rate is about 60 beats per minute. If you see the laboratory parameters of the patient, his HbA1c is 8.3%, eGFR is normal, LDL and HDL are normal, with an elevated triglycerides of about 250 mg per deciliter. And if you see the SGOT and SGPT levels of the patient, they are also elevated at 70 and 100 units per liter respectively. The patient is currently using medication of metformin 1000 mg twice daily, lisinopril of 40 mg once daily, metoprolol 100 mg, atorvastatin 40 mg, and aspirin 81 mg daily. See, if you see this patient, these are the typical patients what we usually encounter in our OPDs. Relatively young patient with a short duration of diabetes, with minor comorbidities without any major complications, with uncontrolled sugars, elevated triglycerides, and a component of non-alcoholic fatty liver disease. And he is on multiple medications. The patient is relatively young. He doesn't have any major comorbidities which will affect the lifespan of the patient, but he is obese, hypertensive, hyperlipidemic, and has obstructive sleep apnea. The patient is at low risk of hypoglycemia, so we can go for a more aggressive or stringent control of diabetes in this kind of patients. So if you see these kind of patients, ADA recommends that in all non-pregnant adults in whom hypoglycemia is not a risk, we should go for a HbA1c target of less than 7%. So going for an aggressive treatment is very important in this patient. So not only that, the treatment that we use depends on the risk of hypoglycemia, the weight loss or the to minimize weight gain of the patients. The chances of getting heart failure or ASCVD or CKD, and the cost of medication also, they should be considered while starting the patients on therapy. If you see this patient, the patient wants to go for a new therapy, but the patient is afraid that he might forget taking his pills. And this is a common problem that we see among the patients. As the number of tablets increases, there are chances that the patient will become non-compliant and they might miss 1 or 2 doses. So in this type of patients, it is better to go for a fixed dose combination because it reduces the pill burden and also decreases the anxiety of the patients, because most of them are worried that they are taking X number of pills per day, like 10 or 12 pills per day, which they are worried about. So if you decrease the pill burden, the compliance increases as well as the goodness feel from the patient also increases. And the other thing is most of the patients are not willing to go for an injectable. So going for an fixed dose oral combination is much better. And if you see most of the patients of diabetes, they will have some of the other comorbidity like hypertension, cardiovascular disease, hyperlipidemia, or like an obstructive sleep apnea in this patient. So a monotherapy cannot address these many multiple defects in the body, and the multiple pathophysiological pathways should be targeted for having a better control. So having an individualized treatment approach in which a combination of therapies are used to treat the sugars are much better as compared with the traditional use of single monotherapies. If you see ADA recommendations also, ADA says that in high-risk individuals with an established type 2 diabetes, we can go for an GLP-1 receptor agonist or an SGLT2 inhibitor to reduce MACE parameters, hospitalizations because of heart failure, CV death, or a CKD progression. And it should be considered independently of the baseline HbA1c or the individualized HbA1c target. So, irrespective of the HbA1c, it is better to start with an SGLT2 inhibitor or an GLP-1 receptor agonist. Since GLP-1 receptor agonists are injectables, most of the patients they prefer taking an oral drug of SGLT2 inhibitors. So in this class of drugs, EMPA and LINA combination is a first-in-class treatment in which a combination of SGLT2 inhibitor and DP4 inhibitor are used, and it's a very good combination to treat these kind of individuals. If you see the SGLT2 inhibitors, they are the new oral glycemic agents that are available. They primarily increase the excretion of glucose through the urine by inhibition of SGLT2 receptors in the proximal tubule of the kidney. And the salutary effect is its ability to act independently of insulin secretion, and it can render it suitable to administer at any stage of the disease course. And DP4 inhibitors, they exert their glucose lowering effect by elevation of incretin hormones and subsequently by augmenting of glucose dependent insulin secretion. So these two drugs act independently of one another, and SGLT2 inhibitors, they act independent of insulin secretion also. And the areas these drugs target are also again varied, and this multi-pathway approach is much better in treating diabetic patients. If you see the outcomes of EMPA-REG study, that is EMPA-REG outcome, it has reported 3-point MACE outcomes to be significantly lower in empagliflozin group as compared with placebo group, about 14% lower. And if you see the other studies that are available for DP4 inhibitors like Carmelina and Carolina trial also, CV safety of linagliptin has been very well established. And if you see the HbA1c decrements by EMPA and linagliptin combination, that is of 25 and 5 mg, the combination decreases HbA1c by about 1.81%, which is very significant. This change was observed at about 6 months of therapy in previously metformin treated group. So after 6 months, the efficacy is about 1.8%, which is very significant. And the benefits, not only glycemic control, the higher percentage of patients also will attain the target HbA1c of less than 7%. And apart from this, the risk of hypoglycemia is very low. There is an improvement in the lipid profile of the patients also, and because of the weight loss associated with this, there can be an improvement in NFLD of the patient also. There is a slight risk of getting genital infections, which is associated with SGLT2 inhibitors. But a combination, the chances of getting are very low, and it can be avoided in patients who had previous history of recurrent UTIs. But if correct patient group is identified and they are treated with this, it is associated with very good clinical outcomes. And in summary, if you see empagliflozin and linagliptin combination, they provide robust HbA1c reduction, which is 2 to 4 times higher as compared with the other reagents, and it is not associated with any risk of hypoglycemia. So the previous case, what we have discussed, in this type of patients in whom the risk of hypoglycemia is not there and who are obese and have a sedentary lifestyle, drug which not only reduces the glycemic control but reduces the weight of the patient and has other additional benefits is very essential. And a combination of empagliflozin and linagliptin, if it is affordable, can definitely be used in these patients, and it is a very good combination as compared with the other combination drugs that are available to us. Thank you.